Hey everyone, today we're going to be talking about special IV medications and with how your scope is written. We always need to make sure that we're paying attention to what is in our scope of practice. Different states write the scope differently, and then different facilities have different procedures. So when it comes to any IV medications, make sure that you are following the scope that is allowed for you within the state that you're in, and then always refer to your facility policies because they're going to change depending on the facility, depending on the training, and let's just be honest, depending on the availability of the different level of nurses. In like Lincoln, we don't have we have a hard time getting nurses, but there's a lot of RNs, so that's why you see at a lot of facilities here they have a little bit different scope for LPNs in facilities than what the state scope is. So just make sure that you are always paying attention and always defer to a facility policy. And if the facility policy is beyond your scope, then you need to have a conversation with your boss and your employer. So we're going to talk about kind of 5 categories of meds that used to be on the LPN no give kind of list, and now the state has opened up that. And so what they are is they are chemotherapy, antidysrhythmics. So we've got our chemotherapy here, or antidysrhythmics, Pitocin, TPN, and then our blood products. So we're going to go through and we're going to talk about each one of these in a little bit more detail, just so you guys kind of get an idea of them. But just know that if you give any of these medications, you are going to have specialty training beyond what we did in our classroom. So let's start with our antidysrhythmics. Here, let me get this zoomed in a little bit. So we're going to start with the one we have here is amiodarone, and that's pretty much our common antidysrhythmic. This is going to be given for a patient that is having a fib, and it's either a new onset or they are no longer stable with their AFibs. So think about when we see people who are having issues with their blood pressure, or they don't look like they're perfusing real well, this is when we're going to start giving some amiodarone. And usually we give a bolus dose and then we'll give a continuous drip. And that's one reason why it becomes kind of questionable for our LPNs, is because we want to know if that patient is stable with their AFib or not. So this is going to be given also if anybody has any type of dysrhythmic event going on. So if they're in VTAC or VFib, so think about your cardiac rhythms. This is when this medication comes in for that. So that's something we're going to have to really think about. Is amio is usually one we give for AFib, but it's really for any type of dysrhythmic, and I can't spell this word to save my life, type of event. So make sure you're really paying attention to if they're having a dysrhythmic event. We need to think about, is that a patient that needs to be where we are, or do we need to send them somewhere else? Let's see. Okay, let's go over, I'm going to drop into Pitocin here. So Pitocin, as you can see with our lovely mom here, this is going to be for our pregnant moms, usually our moms that are ready to not be pregnant anymore. So this is what we call a medication we give when we're trying to induce labor. It's going to come into an IV drip bag. It's going to be titrated and pumped up depending on how you want the labor to go as the nurse. This also can be given to a mom who is hemorrhaging out. All right, so a mom who's maybe already given birth, maybe she had a precipitous birth and delivered too quickly. And so this is a medication that we might give to somebody who is having hemorrhaging after their baby. And so that helps that uterus clamp down. Not usually something we give on the floor. This is primarily going to be given by OB or delivery nurses. I can't say I have ever given Pitocin, so this is not a medication that I know a whole lot about, other than it stays on that OB floor, and God bless OB nurses because they get to deal with all that fun stuff. Let's switch over to chemo. This is one that I do know a little bit more about and have given several times. I also have given amio a lot, but chemo is one that there are some really special things that go with chemotherapy. Notice this setup. You have 2 bags that are set up with this. So you've got like a bag up here, that's the actual chemotherapy, and then you're going to have some sort of flush going down here. The reason we do that is once we give a medication, so I'll kind of draw it off to the side so you can see a little bit better. All right. You know, we talk about we're going to flush our IVs, right? Well, when it comes to chemotherapy, you never want to be exposed to chemotherapy. This is why when we do give chemo, there are very specific safety guidelines that we have to follow. You gown and glove. I know with a lot of meds, I don't talk about needing to glove because we don't need to be safe from it. This is a medication. If this gets on your skin, it will cause burns. It will cause problems. It has to be safety. We wear specific gowns when we give this medication. We are covered pretty much from head to toe for safety. It's always weird when you go walking into a patient's room and you're going to give this medication and they look at you because you are covered and you're about to put this in their vein. So there is a lot of things that go on with chemotherapies that we have to be really careful with. Chemo is can be very toxic to different organs and different systems in that person's body. So there's a lot of monitoring after we give this medication that we have to be protective with. So like when we were talking about how we set it up, right? If the chemo's in here, it's going to infuse, but then we're going to want this medication to go in next so that it flushes through that entire system so that you never actually get exposed to that. Once we disconnect them from it, it's just this fluid that's now been in that entire line once we flushed it through. And that's a huge safety thing. So chemotherapy, you have to be chemo certified in order to give this medication, which is a very long, informative, but challenging class. Lasts a few days usually, and it is usually 8-hour days. It's a long class, but really helps you understand why you're giving what you're giving, where it goes, all of that kind of stuff. All right. So these 3 meds that we kind of talked about first are meds that I wouldn't necessarily see LPNs giving. These are just really specific and really big specialty meds. Now, the other meds that we're going to talk about are meds that I would see more in the LPN scope. All right. So we've got, this is TPN, which is total parental nutrition. It's basically when somebody can't eat or drink and they need nutrients still. We can give TPN. This has to be given in a central line. This is very, very, very concentrated. Okay, it's very concentrated nutrients. It has a ton of glucose in it, usually in the form of like a D10 or even higher. So there's a ton of sugar in this fluid. There's a lot of potassium, which we know we can only give at certain rates. There's going to be sodium and mag. If you ever get a chance when you're at the hospital to see somebody with TPN, just read the ingredients list. It's huge. There's so much different things in there, electrolytes and minerals, all sorts of stuff to help people figure out and rebalance their nutritional levels. So TPN is something we're going to give. Now, this can be given. People take this at home. I've seen hyperemesis moms use TPN for 9 months while they're they vomit everything out and we need to give them nutrients to keep them going. So TPN is something that we're going to do. Now, when somebody's on TPN, it's not just about hooking somebody up to a medication and walking away. We have to, as nurses, we have to understand that we are going to be monitoring them. And what are we going to be monitoring for? Well, think about, we're giving all this sugar. We probably need to know what? We probably need to know what their blood glucose or their blood sugar is. So this might be something that we routinely check, especially in a hospital where they're getting used to it. We may have to check their blood sugars Q6. Why wouldn't we check it ACHS? Why would we check blood sugars Q6? Think about, are they eating? If they're on TPN, they're most likely not eating and drinking for whatever reason. If it's we're needing to rest their bowel because they've had massive abdominal surgery, maybe they have short gut issues and they can't taking the nutrients, or it's a hyperemesis mom and we're going to give them. These people aren't eating or drinking. So, and this is a continuous infusion over 24 hours. So this isn't going to be something that's just sort of a, like you guys have worked with boluses and fluids where it's a, give an antibiotic for an hour. This is something over the whole time or the whole day. So Q6 hours to check our sugars as that's infusing. We're going to be wanting to check labs. Now, which labs would we want to check? Think about that. What labs are we going to be wanting to really look at? A CMP or a BMP, right? Think about what is in those panels. What is in that complete metabolic panel? That's where your potassium is, your sodium, your mag, all of those. Maybe want to check some of our liver enzymes. So you would see a LFT or a liver function test. And we might want to see some of those labs because TPN is filtered through the liver and can be really challenging and really hard. We cannot live on TPN forever simply because it's really, really hard on our liver. TPN, like I said, can be long-term. They can do it for an extended period of time, like maybe while somebody's going through chemo and we're trying to rebalance out nutrients. It is not something that somebody can be on forever just because that liver gets really picky with it. So make sure when we're working with TPN, we know that we're going to have a central line. We know we're probably going to check blood sugars, at least in the beginning. We're going to be checking those. They may have to continue to check them because we will titrate and change the amount of sugar that's in there based on, or the amount of glucose that's in there based on what they're having. But we also will make sure we're checking the rest of these labs. Other things we might want to check, we might want to do some weights, check how they're doing with their daily weights. See if they're retaining fluid. We may want to check some kidney numbers just to make sure those kidneys are filtering well. I mean, TPN is not one and done. It's not like you just do it and then walk away. Like there's a continuous monitoring policies that need to go on for it. So make sure we're paying attention to that. Now let's talk about blood. Okay, blood isn't just, when we talk about blood, there's blood products. So there's a lot that goes with blood. You can see on these that there's different letters. Okay, there's different blood types. You have to get certain blood types. O negative, oops, sorry, I shouldn't have done that one. O negative is the universal donor. So they can give to everyone. AB positive is a universal, it helps if I actually put an S in there, universal recipient. It can take everything. But after that, it starts getting really specific on what can be given to what and what can't be given to each other. So think about what we're doing when we're giving blood. We're giving somebody else's cells, and we do not want somebody to have a rejection or a reaction to someone else's cells. Other things we can see, you see there's plasma. So here's packed red blood cells. Then we have plasma. We can have platelets. Okay, so there's lots of different things that we can give with blood. You'll hear somebody say we've got whole blood, and that means you're getting all of the components together, but usually the components are pulled apart so that we are able to give to different people. Sometimes the color of these products can be a little twinged, like birth control makes plasma and platelets kind of a little green casted to them. So kind of it's weird. You can kind of tell sometimes what medications people were on when they donated. It doesn't change the components of the blood or how they work, but it is stuff that we have to pay attention to. All right, so that's just kind of ideas of what, when we say blood, it's not just necessarily the packed red blood cells. It can be plasma, platelets, and that kind of stuff too. It still we always have to check compatibility and make sure that we're able to give that donor's product to someone else. When we talk about that, it becomes an interesting issue of we have to double check that compatibility, but we're talking about rejection or a reaction. okay, because we're getting someone else's cells. So we have to pay attention to symptoms of that their body is not liking these cells. So if somebody's not liking these cells, we're going to have some pretty significant problems happening relatively quickly. And if you guys have ever worked with somebody getting blood, we usually do a set of vital signs before it, and then a set of vital signs at 15 minutes after the start of transfusion. And then depending on facility policies, some do them Q1 hour, some do them at the end of the infusion, and then a couple times later. So vital signs are kind of depending on facility policy, but you always have a before because you need that baseline. And then you'll always have a 15-minute because you need to see if there's a reaction happening. All right. That doesn't mean a reaction can't happen at the 1 hour mark or at the end, but it does mean that we're looking for something in the first 15 minutes for that body to say, oh, heck no, this isn't mine. So what's a reaction going to look like? A reaction is going to look like the body's having an immune system response. So whenever we have an immune system response, think about elevated temp, because that immune system is starting to activate and starting to fight stuff. We can see a change in blood pressure. Usually it goes up, but every once in a while I've seen it do crazy things and go down. But usually there's some sort of change in blood pressure. Usually our heart rate's going up because the body is freaking out and doesn't know what to do. Sometimes they can have a rash. Think about anytime you've had an allergic reaction to something, you get a rash. It can be itchy. The other thing is we have to think about where the blood product is filtered through once it gets into the system. Okay. And the blood products are always filtered through the kidneys. Okay. And so all of a sudden we'll have people that the kidneys are getting very angry because they're filtering out all these broken blood. Because what's happening as these blood cells are coming through and there's somebody else's blood cells and they're getting attacked by the immune system, they're starting to break apart. And once we start breaking apart, we now have a bunch of, I would say, garbage from the cells being broken up, right? We have these broken cells needing to go through. They're going to get filtered through these kidneys. And now these kidneys are very angry. So they're going to start hurting. When kidneys start hurting, where is someone going to feel that pain? It's going to be flank pain. So they're going to have that kind of backache. All of a sudden, they're going to be like, man, my back is just hurting. And it's going to be up kind of under the rib cage because your kidneys are higher than you think they are, but it's kind of up and it's that flank pain. And so if someone's having flank pain and you know they're getting blood, your first response should be stop it. I don't care if it's your patient, you've gone in the room to help somebody, whatever. If somebody's getting blood and all of a sudden they're having flank pain and their heart rate's starting to climb and they see a temp change, stop that transfusion. Get that stopped and then start calling for help and following your facility policies. Usually we have to send the blood down. They have to double check, make sure it wasn't the wrong kind of stuff, whatever. So that becomes a really big issue. If your facility doesn't allow you to give blood, that's fine, but know that you are still responsible for knowing what a reaction looks like so that you can go into a room, quickly assess, stop the blood, and get help as you need it. What I want to talk about, because we kind of talked about that these are medications that are specialty meds that have special extra training that go with them. Because the scope of an LPN is changing, you need to really follow your policy for your facility and advocate for yourself, because I know nurses get busy. I know we want to help people. But if someone says, hey, here, can you go hang this medication? And you look at it and you're like, I've never hung this medication. I don't know what it is, whatever. You're going to have to say no. And maybe you need to go help take somebody else to the bathroom, or maybe you need to go do some other type of help so that that person can go hang that medication. But know your scope and advocate for yourself. Okay. I know it's hard, especially because you want to be able to do all these skills and it's really cool, but you need to know what your scope is, because I'm going to tell you, RNs, we don't know very well, and we're not very well educated on the LPN scope. And so we just hand you medications. especially in like someplace like St. E's. LPNs and RNs wear the exact same color. So you don't always realize that somebody is an LPN or an RN. You just see the color of scrubs and you get, hey, I need help. I'm drowning here. Help me. So make sure you're really advocating for your scope. When it talks to meds, about medications, one of the biggest things that as an LPN you need to know is stable versus non-stable. And once a patient slips into that non-stable area, that is no longer a patient that is an appropriate that is no longer a patient that is appropriate for an LPN. LPNs take stable, predictable patients. There are a ton of them out there, right? But there are times that stable patients slip and become non-stable, and that's when you need to get them shipped to somewhere or get them to the place they need. That's why these medications are interesting. I don't think an LPN will necessarily ever give Pitocin because that can be a very unstable patient. If that patient's bleeding out, that is not a stable patient. Pregnancy and labor pregnancy itself is a stable, predictable path, but labor is not very stable and oftentimes not predictable. So that can be a really big challenge for an LPN to be in. Somebody who's having a reaction to their AFib. So somebody who's had AFib and no longer is able tolerating it, that is now an unstable patient. Okay, so that medication is not one that I would expect an LPN to give IV. You give amio, it's called Pacerone. You give it orally all the time, but IV is just a different route, right? It's a different route, but it's also faster for a patient that is no longer tolerating or stable or predictable. So I don't see LPNs giving it very often. So make sure again to advocate for your scope. Other things that would be in that is vasopressors is no longer a stable patient. If your patient is on a vasopressor, they are not stable. And so we need to make sure that they're not on your unit and you're getting them to where they need to be, unless it's a patient that is on some sort of vasopressor long term and it's a predictable path, because I know there might be some stuff that comes out that way. Okay, chemo. Chemo can be a stable patient. This might be something that an LPN is allowed to work with because they might be stable. They might come in, they get chemo, they're in the clinic, they're not in a facility or in the hospital. That might be a stable patient. But chemo patients can often become unstable. And we'll talk in another unit about the complications that come with chemotherapy. So that one is one that we really have to go back to. Is this a stable, predictable patient, or is this a non-stable patient? TPN. This is also can be an unstable patient or a stable patient. It can be a hyperemesis mom who's going home and you just need to do some teaching or some reiterating of teaching out in the field with them. Maybe you're just delivering products. There can be lots of different things, but TPN can be a stable, predictable patient. They aren't always. And so that's why we have to understand it. They are given through a central line. So we need to make sure that you know what you're doing with a central line. That your facility is going to have to teach you. That is a specialty skill. All right. And then we want to talk about our blood products. This can be a stable patient, just like the chemo patient. It can be a patient that is going in and getting blood just because maybe they're always low. They're a person that always has they have aplastic anemia or something. They have chronic low hemoglobin. They come in and get blood. They can be stable. But like we talked about with the reaction, they can become unstable very quickly. And so this would be something that we would need to pay attention to, is that this can be a stable patient who just needs a little blood, but now they're unstable. So when it comes to these specialty IV medications, your biggest thing you have to pay attention to is your scope of practice, what your facility is going to do, what trainings they have for you, and if that patient is stable or non-stable. And if that patient is non-stable, that is not in the LPN scope. Stable and predictable totally is in your scope. That doesn't mean you don't get stable patients. It just means you need to recognize they're non-stable and get them to an area where they need help. or where they can help them even more. All right. So I hope this helps kind of not clear all this up, because it's just gonna depend. I know everyone hates it, but it depends. It depends on what a data you have for your patient. What assessment data do they have? What training did your facility give you? And what does your facility expect for you? Remember to advocate for your scope and your skill set. All right. Have a great day, and let's keep learning.